Hi, my name is Kenichiro Imai from Shizuoka Cancer Center in Japan. It's a great honor to have an opportunity to attend this author interview. Here, I'd like to introduce our recent accepted article entitled Higher Incidence of Metachronous Advanced Neoplasia in Patients with Synchronous Advanced Neoplasia and Left-Sided Colorectal Resection for Colorectal Cancer. Here, I invite our first author, Dr. Yabuuchi, to the interview. Dr. Yabuuchi, this is the first question. Why did you feel a need to do this study?
Hi, my name is Yohei Yabuuchi, the first author of this article. Thank you for question, Dr. Imai. Surgical resection is a standard method for curative treatment of colorectal cancer, but there is an increased risk of developing metachronous colorectal cancer in the remnant colorectum after surgical resection of the initial colorectal cancer. Surveillance colonoscopy after curative surgery could reduce the incidence and mortality of metachronous colorectal cancer by early diagnosis of recurrence at a curative stage or by detection and removal of metachronous precursor lesions. Although the recently published recommendation of the U.S. Multi-Society Task Force noted that colonoscopy should be performed 1 year after surgical resection of colorectal cancer, the optimal timing of the subsequent colonoscopy remains unclear, as there is little information regarding the long-term occurrence of metachronous lesion after the first post-operative colonoscopy. Therefore, we focus on the incidence of metachronous high-risk lesions that were determined to be advanced neoplasia, the surrogate marker of colorectal cancer. It would be helpful to identify the risk factor for metachronous advanced neoplasia in order to determine the most appropriate surveillance intervals. Recently, it was reported that there was a higher risk of development adenomas after left-sided colectomy than right-sided colectomy. In addition, numerous studies indicate that metachronous advanced neoplasia after polypectomy is significantly associated with baseline polyp characteristics. Thus, we hypothesize that metachronous advanced neoplasia after surgical resection of colorectal cancer might be associated with the surgical resection site and with synchronous advanced neoplasia.
Okay, I understand the study background. So, what does this study add to existing knowledge?
Colonoscopy surveillance after polypectomy was based on the findings at baseline colonoscopy. This study shows that even after surgical resection of colorectal cancer, the baseline colonoscopy finding, that is whether there was a synchronous advanced neoplasia or not, was associated with metachronous advanced neoplasia. However, as for the resection type, it was not independently associated with incidence of metachronous advanced neoplasia. Interestingly, in subgroup analysis of patients after combining resection type and synchronous advanced neoplasia, patients with synchronous advanced neoplasia who underwent left-sided colorectal resection had a significantly higher probability of metachronous advanced neoplasia than the other groups. Furthermore, the probability of metachronous advanced neoplasia in patients with synchronous advanced neoplasia who underwent right-sided colorectal resection was similar to the probability in patients without synchronous advanced neoplasia.
Okay, this is the final question. How might it impact on clinical practice in the near future?
So our results showed two separate risk levels. The patient with synchronous advanced neoplasia who underwent left-sided colorectal resection had a remarkably increased risk of metachronous advanced neoplasia than the other groups. The 3-year cumulative probability of metachronous advanced neoplasia was as high as 15.6%. This result may potentially indicate the recommendation for shorter interval surveillance than 3 years in patients with synchronous advanced neoplasia who underwent left-sided colorectal resection. Our study was performed at a single center setting. We consider the risk stratification according to synchronous advance of neoplasia and resection type merits further investigation at multi-center setting in order to determine the appropriate surveillance intervals after surgery for colorectal cancer. Thank you very much for your kind attention.